Welcome to the 3030 Health Podcast. The following discussion is for education and entertainment. It is not intended to diagnose or treat disease. Please do not apply any of this information without first discussing it with your doctor. Here is your host, Dr. Ruiz.
Hello everyone, super excited about the show today. In today's episode, we will be answering some of our listener questions. But first, a word from our sponsor, Integrative Health Thyroid Advisor.
Hey there, Dr. Alan Christensen here with you. I'd love to take just a moment and tell you about our Thyroid Advisor program. So what is the Thyroid Advisor visit? Well, imagine that one of your closest friends happened to be a thyroid doctor and that they understood the conventional, the naturopathic, and all the functional approaches. They just wanted you to feel better and they were happy to video chat whenever you needed them. So that's basically it. Just click the link to set up a time and the IH docs are happy to help out today.
Hello everyone, super excited to be here with my friend Adam Sadowski. Adam, how are you doing, man?
Awesome. I got the results not too long ago, and I passed, and I was super happy about that. Very stress relieving. So today I was working on my systematic review, and the systematic review is on heart rate variability, which Dr. Mike T. Nelson knows a lot about, and I think Dr. Ruiz, you had an interview with him a little while back. So if anyone's interested, if they want to listen to that episode, go ahead and check that out to kind of familiarize yourself with that. But I am looking at heart rate variability and its association with IBS and IBD. So IBS is irritable bowel syndrome and IBD is inflammatory bowel disease.
And has Mike has he been helping you? Have you consulted with him?
I talked to him a little bit right before I started the study just to make sure, all the measurements I was looking at are correct. And he basically said, yeah, but I haven't had too much direct contact with him about that. But I'm definitely going to probably reach out to him again later on as the study progresses towards the end.
He would be a really good reviewer, because just to make sure that all your ducks are in a row.
Oh, yeah, totally.
So yeah, so super busy with the practice. We have a new sponsor. I don't know if you guys heard the little ad at the beginning of the episode. We go to conferences or we do a Facebook Live, and people are always asking, how can I, get a doctor like you? Well, now you can. We created the infrastructure to be able to take patients from out of state. And I have a link in my page, and you can actually click there. You can. We have a partnership with mylabwork.com. You can get your labs through them, and then we can sit for a conversation and discuss your labs and give you ideas on how to proceed with your health. So very excited being able to offer this to people that maybe don't have, the time or the capacity to come see us in Scottsdale, Arizona. So very excited about that.
Awesome.
So Adam, a couple of things, got some laundry list stuff. I heard that you will be presenting at a conference here pretty soon.
Yeah, I will actually be presenting at the AANP. So that is sort of the main naturopathic physician conference. It's going to be held actually here in Portland, Oregon.
And I will be crashing with you because I will be there. That's in when? August?
That is August 15th, which is actually the day of the summer boards. So I'm very happy that I passed on the first try, because that means that I would have missed that and I wouldn't have been able to present. I'll also be seeing you at AHS in San Diego probably the week before.
Yeah, so we're gonna be best buds for a couple of days there, man. Do you have a poster at AHS?
I believe I'm working with Rob Abbott on that. Yeah, and that's going to be on Hashimoto's thyroiditis and the autoimmune paleo.
Oh, that's awesome.
Protocol. Yeah.
Yeah, and I will be presenting at PaleoFX. That's coming up in April, and that's going to be super exciting. I love that conference. And then I will be also presenting at the Ancestral Health Symposium. And my presentation at the Ancestral Health Symposium is going to deal with a lot of these markers that I want to talk about today. I wanted to do a little bit of a short podcast. There's a new article Dr. C just published about reverse T3, and I want to go deep into the implications of reverse T3, TSH, T4, and T3, and how those lab markers affect you. I know we've talked in the past about TSH at length, so I'm going to dedicate more time to reverse T3, T3, and T4. I want to talk today about blood markers that get a lot of play in the blogosphere, and they get retweeted and they get posted on Facebook, and there's a ton of confusion in how those markers relate to some of the symptoms of autoimmune thyroiditis and how we correct those markers. So a couple of weeks ago, Dr. C, my boss and mentor, I love the dude. He posted an article on his website called "What's the Deal with Reverse T3?" And we have been, going back and forth about this for a while, and it took a long time to write this article. And it's about 5,000 or 7,000 words. It's very comprehensive. And we get a lot of questions about reverse T3. Should I test it? Why is my doctor not testing it? What's the deal with reverse T3? He basically sat down and scoured all the literature and wrote this beautiful article about like how it became a thing, what does it mean, and how can we clear the confusion with this marker. So, Adam, do you know what reverse T3 is?
Yes. So reverse T3, if you want to get super nerdy, is reverse triiodothyronine, and it's just a metabolism marker of thyroid hormones. The best way that I know of it is it's a marker that a lot of people like to use to see how their thyroid is functioning, but not necessarily from the conventional standpoint in medicine, and that it is usually elevated in severe burn victims, and that's honestly my extent to reverse T3.
Yeah, and it came to popularity because reverse T3 takes active T3 and basically deactivates it, okay? And the idea in the health space is that if you have really high levels of reverse T3 or even within the range, in the higher range of reverse T3, if it's elevated, it was assumed and it has been popularized as your body doesn't know what your body's doing, and it's deactivating T3, and that's the reason you feel like shit. Basically, so people started measuring reverse T3. In some cases, it was with a normal range. In other cases, it was elevated. And then people started saying, okay, that's the cause of your fatigue. That's the cause of your malaise. And that's the reason your thyroid is not functioning. So we need to increase your T3 to compensate for the elevated reverse T3. Okay. Reverse T3 was discovered first when it was being measured in patients in the ICU. These patients in the ICU, for some reason, whenever they were septic, the reverse T3 would go up. And it was an explanation of, we really don't truly understand why on ICU patients that reverse T3 goes up. There's theories about, protecting you from sepsis, but we really don't understand. But what we do understand is that reverse T3 is a mechanism to prevent oxidation from high levels of T3. And we see higher levels of reverse T3 in patients that are being over-medicated with T3. So if you want a sure way of increasing your reverse T3, give someone more T3. It's so interesting because, we sometimes try to be smarter than our physiology. And we think that we understand the body better than the adaptive mechanisms that have been, being curated over millions of years for us to be protected. Remember, your thyroid hormone increases metabolism. And if you have an unchecked metabolism, you're going to run through cells, you're going to run through mitochondria, you're going to create a lot of oxidative damage. And that oxidative damage is basically going to destroy that cell because you don't have the detoxification pathways to keep up with that oxidative damage. I've said it before on the podcast. I like to compare this with rampant utilization of glucose. Okay, so what does your body do? It becomes insulin resistant to prevent the oxidation of that glucose because that rampant oxidation is going to kill that cell faster. So in essence, we could basically end the podcast right here and say, okay, you want to decrease your reverse T3, check your TSH. If your TSH levels are okay, between the functional range of 0.5 and 1, and your T3 levels, are okay, then two things happen. Your reverse T3 is going to go down to the normal levels, or it doesn't matter. The cause of your fatigue is something else, and we should be looking at that something else and not try to beat this dead horse. But we have to make this more interesting for the people that tuned in, and we're going to have to spend some time with why was this reverse T3 implicated as the culprit in your causes of fatigue. It goes back to things like the Wilson protocol and the idea of finding a different way of getting, you healthier. Now, Dr. C tells the story, and I'm going to link this blog post, and I want you guys to go read it because he really goes deep into the history of alternative thyroid views. He has been interested in endocrinology for a very long time. And back when he first started practicing, the TSH range was 0.5, and, don't quote me on this, up all the way, into like an astronomical number, 12. Okay. So you would go to your lab, you would get your labs drawn, and then you would see, if it was like a 9, you were okay. You didn't have hypothyroidism. And this is before we had other markers like thyroid antibodies and things like that. So a lot of people, a lot of people were misdiagnosed as being normal when their TSH was elevated. And then there were a couple of doctors who started noticing that if their patients had better TSH levels, the patients started feeling better. And one of the proponents and one of the people that started pushing this, let's reduce the TSH levels, was Dr. Broda Barnes. And Dr. Broda Barnes was one of the pioneers of trying to figure this out. What's the perfect TSH level? So Dr. Broda Barnes started dosing patients with thyroid medication, and it started seeing that as that TSH level was getting closer to the lower range, the patients got better. Now, the truth lies somewhere between this functional medicine thinking and the conventional thinking. And with the conventional thinking, getting it wrong and setting that TSH level that high, and the functional medicine world thinking that sometimes ignoring lab values or pushing the envelope even more is going to be very helpful for the patient. So within all of this, okay, between the 1990s up until even now, the Wilson model of thyroid came about, and Dr. Wilson proposed that in order for you to know what your real thyroid level was to take your temperature and try to get your temperature to 98.7. And anything below 98.7, that meant that you were hypothyroid. And this is ignoring TSH levels, ignoring free T3, free T4, ignoring all of those markers that have been well established. Now, there are a lot of papers out that demonstrate that your core body temperature is highly variable. and it really does not correlate with your thyroid function. But because this person created or proposed this idea and actually started, treating people with high levels of thyroid, and it got propagated. Maybe a lot of people had not been diagnosed properly with hypothyroidism, and they started, following his work or whatever, and some people got better, they started feeling better, and then it started becoming popular, and people, buy their thermometers and they check their temperature, and if they notice that their temperature is cold, then they start dosing that medicine according to their temperature, completely ignoring the dangers of being hyperthyroid. And I can make an argument that being hyperthyroid can be more dangerous than being hypothyroid.
Hypo being more dangerous than hyper, or hyper being more dangerous than hypo?
Yeah, I can make the argument that hyperthyroidism is more dangerous than hypothyroidism, because in hyperthyroidism, you are increasing oxidative damage. You are forcing your heart to work harder. You are, turning bone over. You are turning cells over. And just ask any patient with Graves' disease that has been irradiated and then became hypothyroid. Most patients are going to tell you that their Graves' symptoms and being hyper was way worse than being hypo. You feel anxiety, you are basically about to, explode. And the danger doesn't end there. You can damage heart tissue, and you can give yourself, congestive heart failure. There are case reports of people, having heart disease iatrogenically induced by taking too much thyroid medication. And then when this reverse T3 marker was discovered, after the fact, then that's when the idea was like, oh, the reason why people are not, have normal TSH and they are still cold is because of this reverse T3. And in reality, that is not the case. That is not the case. So a couple of questions that we hear in our office, a lot of times are you going to test reverse T3? And for a while there, I was doing it. And I realized that my medical decisions were not affected by the level of reverse T3. Because whenever I got those results back, if a person had been to different doctors and they couldn't control that thyroid function and they were being underdosed, that reverse T3 wasn't a problem. And then we just started them, in a conservative model of thyroid medication, and we checked the right markers, and they got better, and that reverse T3 was non-consequential. And if a person came to us because their thyroid wasn't being controlled, and the previous practitioner had been using something like the Broda Barnes model or the Wilson model, I knew that they were hyper. And if that reverse T3 was elevated, I would reduce the thyroid medication, and then that reverse T3 became not a problem. So I really didn't need that marker in order for my medical decision making. So I don't find it necessary for people to be testing the reverse T3. And it's crazy because, if a patient comes to me and they want to test the reverse T3, I will honor their autonomy and I will order a reverse T3 for them so I can show them that is non-consequential, because the last thing I want is to be on a pedestal and deny care to my patients. They are the boss. But I make a very strong case on why it's really not necessary. So this story gets even more interesting because the idea was like, okay, let's defeat this reverse T3, and maybe if we blow through the threshold of your body that your body can sustain, let's blow through it and let's give you a lot of T3 and get your free T3 levels really high. Okay. Well, the body's smarter than our, this millions of years of evolution are way smarter than this short period of knowledge that we have about modern medicine. And something really interesting happened the other day. While looking through the literature, we found that in obese individuals, when that TSH begins to climb, so they're becoming hypothyroid, that T3 starts to climb, that's an indication that they are consuming too many calories, and those calories that they're consuming are higher than their resting energy expenditure. And I'm going to link that article on this podcast. So basically what's happening is that your body is starting to not accept that T3 because those calories are creating a big burden of oxidation. And because those reverse T3 is not just used to for calorie expenditure and to break down fat cells, it's used for your immune system. It's used to grow bones. It's used for a lot of things. Your pituitary begins to think that you are hypothyroid. How crazy is that? Now, what's the implication of this? Well, the implication is that if you're just taking T3, you might put yourself in that scenario where you're becoming thyroid resistant, and now your body is going to think that you are hypothyroid, and you're going to create this environment where your calories are not going to be utilized in the right way. So it's super interesting because a lot of people in the past, and you can see it, you see it in like T-Nation forums and things like that, people using T3 for weight loss.
Yeah.
Not only is it dangerous because you can give yourself a heart attack, you can give yourself osteopenia, you can, you're going to have anxiety, your hair's going to fall, you're going to have nervousness. In the end, even if you go through it, you're going to be utilizing less calories.
Huh.
Yeah, it's kind of crazy. So what do we do about this, really weird scenario with the reverse T3 and the T4 and the T, and all of this crap? Okay. Just go back and try to normalize those hormones and try not to be in the supraphysiological state with those hormones. And it sounds like it sounds so middle of the road, and it's not as sexy as we have the answer. The reason is reverse T3, and this one mechanism in one part of this whole physiology is the reason. No, we need to adhere to our physiological laws, and we should be balanced, not hyperthyroid. And how do we do that? By checking your TSH levels, making sure that your conversions are fine. Your T4 to T3 conversion is fine. Some people do have some trouble converting the T4 into T3. Making sure your gut is healed and solid so you can actually absorb your thyroid hormone if you need thyroid hormone. And then if your problem is hypothyroidism, you should start to feel better. The problem is that some people, do that, and that's just a part of the big puzzle. And maybe they get 50% better, 60% better, but not all the way through. In those cases, you need to investigate what the underlying cause of your symptoms is and not just give more thyroid hormone.
So, Dr. Ruiz, in the outpatient setting, not being in a hospital or an area where you're probably going to encounter someone with some sort of severe
sepsis,
a case of some sort, when would it be indicated then to, check reverse T3 outside of a patient just really, 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 really wanting to get a check?
I want to make the argument with this show that you don't need to check your reverse T3. And it's a little bit controversial, but I just, I've seen it over and over in practice, and it's expensive to be healthy in the United States of America. Okay. And if I can give my patients a little bit of conservative medicine that is effective, and at the same time not increase the money spent in our healthcare system, I think that's, I'm willing to stick my neck out for something like this. I understand that, again, the truth lies somewhere in the middle from, this antiquated conventional model and this radical, super, extremist model of functional medicine. And I am willing to stand up for A, what the science says, and B, what the outcomes say, and make an argument today that maybe your reverse T3 is not that important. Again, the truth lies somewhere in the middle. So sometimes you hear, I have patients that come in and then, they go to the conventional doctor and their TSH, like the reference range is, depends on the lab, but sometimes it's 0.45 to 4.5, and they go to the doctor and they see the TSH levels, and the TSH levels is a 4. And the doctor is going to look at the lab, and they're going to say, oh, everything is within the range. You are fine. Here's your crazy pill, And that's bad. That's really bad, because we have studies that show that when you take out people from the studies that have nodular changes in their thyroid and people with the best longevity outcomes, and I will post this paper on this on this show. Their TSH levels are somewhere between 0.5 and 1. People without any Hashimoto's, people without any autoimmunity, people that are converting their T3 to T4 perfectly, that maybe didn't have a past infection that created an autoimmune disorder that now you're attacking your thyroid, people that don't have HPA axis dysfunction, their TSH is going to be between 0.5 and 1. You start seeing problems, overt problems in your thyroid when you can start seeing goiters and you can start seeing nodule growth, and once you get past 4.5. So why are we waiting for that marker, for that TSH to be elevated past the 4.5 to do something about it? At the same time, if someone shows to my practice and their TSH is a 2, and we do an ultrasound and there's no nodules, and they are tired, and maybe they have some hair loss, and maybe they're gaining weight, and their T3 and T4 are middle of the road, I'm not going to start them on thyroid medication just being aggressive and saying, oh, you're not between 0.5 and 1, this is the cause. So somewhere in the middle, the treatment should take into consideration that there are other things that affect your thyroid. Again, in the conventional model, if you are hypothyroid, you would probably be started on something like levothyroxine, okay, which is just T4. And levothyroxine can be effective at lowering your TSH. But should we just be concerned with the change in lab value, or should we look at other factors that could be contributing to you feeling sick? And I will post this paper talking about the difference between natural desiccated thyroid versus levothyroxine. In this paper, what it states is that, yeah, levothyroxine is as effective as natural desiccated thyroid at lowering your thyroid levels. The difference is that people that were given the natural desiccated thyroid versus the people who were given the levothyroxine, the people in the natural desiccated thyroid group had more resolution of symptoms when their TSH was normalized than the people that had normal levels of TSH only on the T4. And the idea behind that is that because the natural desiccated thyroid has T3, T4, a very rarely talked about hormone called T2, and it's basically your thyroglobulin. Instead of having 4 iodines like T4 or 3 iodines like T3, it only has 2 iodines. It also has thyroglobulin. Because it has a more complete spectrum of the hormone, the natural desiccated thyroid is acting on pathways that we might not understand at this point. There has been some studies into T2 specifically, and some of the studies are not super convincing yet, but I like that the science is moving into that direction, trying to look at what the hell is T2 doing. And some of the things that I've seen about T2 is that it helps with weight loss.
Interesting.
Yeah, it actually, one of the studies that I read is that it's acting on fat cells. Not super ultra convincing, but it's very promising. So again, I understand how someone that goes to a conventional doctor might be very dissatisfied and kind of tired of someone telling them, oh, there's nothing wrong with you, when their labs show something might be very wrong with them. And then turning around, going on social media or the internet or whatever, and starting to read these very radical ideas and actually, trying them. But the problem with these radical ideas is that they can be very dangerous. So I thought it was like super important to really try to hit this. And I seriously, I will post the link to the article about, reverse T3 on my blog. And it's a fun read, and I really want you guys to read it so you guys can get a little bit more in-depth understanding of how is reverse T3 modulated within the body, and how T3, T4, and TSH play a role in that modulation, and most importantly, why TSH is so important and probably the most important marker when it comes to your thyroid. So yeah, man, I know, this was like a fast one, and we really pulled this out of our asses. But, what are the plans for the rest of the week for you?
Plans for the rest of the week are to work on my systematic review, and then I'm actually on spring break right now. So probably just take a little bit of a break from, it was a pretty hectic term, and just kind of, recover a little bit from that. And then I got the term starts up again on Monday. So, back to the grind.
Yeah, awesome. And how much longer do you have before you graduate?
So after next term, that's technically like my last academic term. And then after that, it's strictly clinical based. So I still have about a year and a little bit left. So my graduation is in 2020.
Oh, that's like right around the corner.
Yeah, it's kind of scary.
Yeah, no, I am working in a couple of really cool projects right now, and trying to bring good content to the podcast. And I need to start being a little bit more active on social media. I've been taking like a little sabbatical, so hopefully you'll start seeing me posting and commenting here in the near future. But thanks for listening, and Adam, I'll talk to you soon, man.
And everybody listening, let us know what you think about this kind of new format. Do you like the longer podcast or do you like the shorter one? Talk to you later, Dr. Ruiz.
Awesome, dude. Thank you.